Welcome to the deep dive. Today, we're heading into a really intriguing area where medicine meets the pressures of extreme environments.
Yeah, it's fascinating stuff.
We're going to unpack how drugs behave when the air pressure goes way up, specifically the world of medications in hyperbaric oxygen environments. And our trusty map for this journey is the textbook Hyperbaric Medicine Practice.
That's right. We've got a whole chapter dedicated just to this, and it's packed with crucial information about using medications when the pressure's on, literally.
It sounds like a field with a lot of unexpected twists and turns.
Definitely. Things that have real implications for keeping patients safe and making sure treatments actually work as intended.
Okay, let's unpack this. So, if you've ever wondered how medicine works in these unusual settings, our goal today is to give you the essentials.
Huh.
We'll look at how hyperbaric oxygen can affect storing drugs, how the body might process them differently under pressure. That's the pharmacokinetic side, right?
Exactly. Pharmacokinetics.
And then how the drugs themselves might interact with the increased oxygen levels, the pharmacodynamics.
That's the other piece, yes.
We're aiming for a clear picture, maybe some aha moments, without getting bogged down in, super technical jargon. So where do we start our descent into this?
I think the most logical place to begin is right there in the chamber. The immediate surroundings. How that environment affects the drugs in their containers.
Right, practical stuff first.
It's a more significant factor than many might initially realize, actually.
Absolutely.
Yeah.
These aren't your standard pharmacy shelves. What kind of stresses does this high-pressure environment put on our medications?
Well, the main thing is just the sheer atmospheric pressure. Inside these chambers, the pressure can get several times higher than normal sea level.
Wow.
Think of it like being deep underwater. That kind of force can really test the integrity of packaging.
Right, like squeezing something. So how does this affect different types of drug packaging? Let's start with the common glass vials.
Generally, glass vials are surprisingly tough.
Hmm.
They can usually handle pressures up to about 6 times normal atmospheric pressure, 6 atm.
Okay.
But there are some important caveats, especially with larger vials, say 10 milliliters or more.
Mm-hmm.
At pressures above 3 atmospheres, there's a risk they could implode, basically get crushed inwards by the pressure.
Oof, that sounds dangerous.
It could be, yeah.
Yeah.
So the advice is either wrap the vial in gauze. When you need to open it, gives it some protection. Or even better, draw the medication out using a syringe outside the chamber and then just bring the loaded syringe in. Smaller vials, like 3 milliliters or less, seem to be much more stable. Less of an issue there.
Okay, so size matters for glass vials under pressure. What about those multi-dose vials? They're pretty handy normally.
Multi-dose vials bring up a different set of problems in a hyperbaric setting. Once you puncture that seal to take out a dose, you really shouldn't repressurize them.
Why not?
Well, when the chamber pressure increases, air can actually get forced into the vial through that puncture point. And then, when the pressure comes back down during decompression, the contents can get pushed out. Plus, every time you puncture it, there's a contamination risk.
Right, you don't want that.
Definitely not. So the safest approach is just to discard any multi-dose vial that's been accessed after the decompression cycle. Doesn't matter how much is left. It's basically a one-use possession deal.
That makes total sense from a safety standpoint.
Mm-hmm.
Okay, now let's talk intravenous infusions. We're often dealing with larger volumes of fluids here.
Yeah, for 5E infusions, flexible plastic bags are definitely the way to go.
Okay.
They can adjust to the pressure changes inside the chamber without major issues. Glass vials can still be used, but they need very specific handling. You absolutely need vented tubing.
Vented tubing.
And crucially, the needle or spike on that tubing has to go all the way to the bottom of the vial, below the liquid level.
Why is that vented tubing so critical with glass IV vials? What's the risk if you don't use it?
Okay, think about it. As the pressure in the chamber goes up, any air trapped above the liquid in the glass vial gets compressed. Smaller volume.
Right.
That's usually okay on the way down. But when the chamber decompresses, that trapped air expands again.
Okay.
If you don't have a vent, that expanding air has nowhere to go except to push the fluid out, potentially very rapidly, to the patient.
Oh, wow.
Followed by potentially a large bubble of air. Depending on the vial size, that could be a significant air embolism risk. Very dangerous.
So the vented tubing lets that expanding air escape safely.
Exactly. It acts like a release valve.
Yeah.
If you somehow don't have the right vented tubing, you could temporarily stop the infusion during decompression and flip the bottle upside down so the vent is at the top, letting the air out without pushing fluid. But vented tubing is the standard.
That sounds like a really critical detail. easily overlooked but with potentially severe consequences. And you mentioned even sealed glass vials might pose a risk after repeated pressure changes.
Yes, that's right, even unopened ones. There's a documented case where a sealed 500 milliliter saline vial actually exploded after being decompressed from a high pressure around 6 atmospheres.
Exploded outwards.
Yeah, this happened after it had gone through multiple cycles of compression and decompression. The thinking is that over time, maybe a tiny amount of air got forced in, and the repeated stress just weakened the glass eventually.
Oh,
It's a good reminder that even seemingly stable packaging can be affected by these extreme conditions over time.
exploding saline vials, definitely not something you encounter every day. Okay, let's shift gears a bit to how the drugs are actually administered inside. What about infusion pumps? Are those generally safe?
Battery-powered infusion pumps are usually fine.
Okay.
If a pump needs to be plugged into mains power, though, there are very strict safety rules. You need special explosion-proof plugs that lock securely, and the power has to come through an isolation transformer.
Right, because of the oxygen-rich environment.
Exactly. Interestingly, the official guidelines from the National Fire Protection Agency, the NFPA, have been updated. The chamber atmosphere isn't technically classified as explosive anymore, but it's still considered a hazardous environment.
So still requires precautions.
Absolutely. Some electrical gear that used to be totally forbidden might be allowed now,
Yeah,
but you always have to follow the latest safety standards.
understood. So intravenous administration seems like the most reliable way to get drugs into the system in the chamber. But what about other common routes, like injections under the skin or into muscle, or just taking pills?
Yeah, the IV route is definitely the most predictable. For intramuscular, IM, and subcutaneous SC injections, the initial thought was, well, hyperbaric oxygen causes vasoconstriction, right?
Narrowing of blood vessels, yeah.
Right, it can reduce blood flow in normal tissues by up to 20%.
Yeah.
So the concern was this might slow down or reduce how much drug gets absorbed from the injection site.
Makes sense intuitively.
But studies haven't really borne that out. For instance, there was a study on midazolam, a sedative, given IM. They found no delay or decrease in the peak drug levels under pressure.
Huh.
In fact, sometimes the peak levels were reached even earlier at 2.8 atmospheres compared to normal air pressure.
Earlier. How does that work?
Well, midazolam is quite lipophilic. It dissolves easily in fats. That might play a role. We still need more research on drugs that are more hydrophilic, more water-soluble.
Okay, interesting. So even with vasoconstriction, absorption isn't necessarily worse for some injected drugs. What about taking pills? Oral absorption?
Oral absorption also seems to be generally unaffected by hyperbaric oxygen. Although, again, there are some theoretical possibilities for interaction, like maybe changes in blood flow to the digestive system could play a role,
Maybe.
but we don't have a lot of direct studies specifically looking at oral drugs under HBO conditions.
And transdermal. Patches and creams.
That's a different story. Transdermal absorption is highly variable, depends a lot on the specific drug formulation and how well it penetrates the skin under these conditions. The general recommendation: remove any transdermal patches or creams before going into the chamber. It's just considered too unreliable in there.
Good to know. What about inhaled medications like asthma inhalers?
Aerosolized pulmonary medicines, like in standard inhalers, probably don't have significant changes in absorption
Why is that?
because the drug is already in tiny liquid droplets. It's not a gas that would be directly affected by the pressure changes in the same way. However, if you're dealing with a truly gaseous drug that's inhaled,
Mm-hmm.
then the increased partial pressure of that gas in the hyperbaric environment will create a stronger driving force. It'll push more of the gas across the lung membranes into the bloodstream. So, increased absorption for gaseous drugs.
Okay, that distinction makes sense. So we've got a better picture now of how the environment affects drug storage and how they get into the body. Let's dive into pharmacokinetics, how the body actually processes these drugs once they're in. We're talking absorption, distribution, metabolism, and elimination, right? The whole ADME picture.
Exactly. Those are the 4 key steps. And while there are many theoretical ways that the increased pressure and oxygen could potentially influence these processes, the current evidence suggests that for single doses of most drugs, a short, acute exposure to hyperbaric oxygen doesn't cause major changes in how the body handles them overall.
Okay, that's somewhat reassuring. Let's take it step by step, though. We've touched on absorption with the different routes. Anything else from a purely pharmacokinetic angle?
Just to sort of recap and emphasize,
Mm-hmm.
for IM and SC injections, despite the intuitive idea about slower absorption due to reduced blood flow, the midazolam study suggests it's not always the case, especially for those lipophilic, fat-loving drugs. We really need more data on hydrophilic ones. For oral meds, the theoretical concerns are mainly around potentially slower absorption from reduced gut blood flow and maybe high oxygen affecting metabolic enzymes in the gut and liver. But again, mostly theories, not much direct human data. Meds given via mucous membranes intranasal, buccal might be less affected by changes in liver metabolism since they bypass that first pass, but absorption that way can be inconsistent anyway.
Okay.
And yeah, as we said, inhaled gaseous drugs definitely increased absorption due to pressure.
Right. So absorption has some theoretical question marks, maybe some specific cases, but not loads of strong evidence for big general changes. What about distribution? How drugs travel around the body?
Distribution, yeah. That depends on a drug's chemical properties, like does
Yeah.
it prefer fat or water? Does it bind to proteins in the blood? How easily does it cross barriers like the blood-brain barrier?
Okay.
One theoretical concern was that the increased free radicals, those unstable molecules produced in high oxygen, could maybe interfere with protein binding. Well, many drugs hitch a ride on blood proteins. If they get knocked off, you might have more free, active drug floating around, potentially stronger effects. This could be relevant for drugs that are normally highly protein-bound, like phenytoin or valproic acid, but we don't have specific studies looking at this under hyperbaric oxygen conditions. It's a theoretical possibility.
Gotcha. Any other distribution concerns? Like
Yeah.
getting into the brain?
Yeah, there was also an idea maybe those free radicals could make barriers like the blood-brain barrier leakier. But animal studies using antibiotics like topramycin and gentamicin didn't find significant changes in how much drug got into the cerebrospinal fluid under HBO.
So, not much evidence there either.
Seems unlikely that hyperbaric oxygen drastically alters how most drugs are distributed,
Yeah.
based on what we know now.
Okay, that's good to know. Now, metabolism, how the body breaks down drugs. This sounds like it could be really complex with all the enzymes involved.
It is intricate, yeah. Drug metabolism mainly happens in two phases. Phase I involves enzymes, famously the cytochrome P450 or CYP450 family, doing initial tweaks like oxidation. Phase II then usually sticks other molecules onto the drug to make it more water-soluble, easier to get rid of.
And enzyme activity can change.
Oh yeah, lots of ways. How much enzyme the body makes, other things binding to it, competition from other drugs. Now, animal studies have shown that just being in high oxygen can actually increase the production of some CYP450 enzymes over time.
Suggesting faster breakdown?
Potentially, yes, with chronic exposure. However, test tube studies using rat liver cells showed that high pressure could actually slow down the activity of some CYP450 enzymes, but not others. It varied depending on the specific enzyme.
So pressure and oxygen effects might pull in different directions or affect different enzymes differently.
Exactly, it's complex. And interestingly, when those cells were first exposed to low oxygen than high oxygen, the breakdown of some test drugs actually increased.
Yeah.
Then, in live rats with long-term exposure to HBO, some metabolic reactions, like breaking down morphine, were faster. But again, it depended on the specific enzyme. Cocaine metabolism wasn't changed, for example.
So the animal studies give us some mixed signals, some hints. But what about humans? That's really what matters for clinical practice.
Precisely. And human data here is really scarce. One study did look at caffeine metabolism, and it didn't seem to be faster in people exposed to hyperbaric oxygen.
Okay, that's one data point.
Right. But given the animal findings showing changes in some enzyme activities, we can't completely rule out that other drugs might be metabolized differently in humans under HBO. The changes in enzyme production seen in animals usually take days or weeks.
Right.
But those immediate inhibitory effects of pressure on some enzymes seen in the test tube, that suggests potential for quicker interactions. We just need to be aware.
So a lot of we don't know for sure when it comes to metabolizing drugs under pressure. Let's move to the last step, elimination, how the body gets rid of drugs. We're talking things like half-life, clearance rates.
Correct. Elimination is removing the drug from the bloodstream, often measured by the beta elimination half-life time for the blood concentration to have. This depends on clearance, how much blood is cleared of the drug per unit time and volume of distribution, basically, where the drug goes in the body.
And clearance usually involves kidneys and liver.
Primarily, yes. Renal clearance and hepatic clearance. Now, since high oxygen and pressure can sometimes reduce blood flow to organs, there's a theoretical concern this could reduce kidney function, slow down the elimination of drugs cleared by the kidneys, making them hang around longer.
Makes sense. But
a study looking at gentamicin, an antibiotic mostly cleared by the kidneys, found no significant difference in its half-life, volume of distribution, or total clearance in healthy people breathing hyperbaric oxygen compared to normal conditions.
That's another result that kind of goes against the simple theoretical expectation. What about drugs mainly handled by the liver?
How quickly the liver clears a drug depends partly on its hepatic extraction ratio. High extraction ratio drugs mean the liver is very efficient at removing them on the first pass, so clearance is mostly limited by liver blood flow.
Okay.
Animal studies suggested HBO might increase liver blood flow in rats, which could mean faster clearance for these drugs.
But in humans?
Studies in dogs with meperidine and in humans with lidocaine, both high extraction drugs, showed no change in clearance under HBO.
Hmm.
So maybe the blood flow change isn't significant in humans, or other factors balance it out. Now, for low extraction ratio drugs, clearance depends more on the liver enzyme activity itself.
Right, which we said might be affected.
Theoretically, yes. Since HBO could affect CYP450 enzymes, these drugs could be impacted. However, studies with theophylline and pentobarbital in dogs and caffeine in humans, all low extraction drugs showed no change in their total clearance or disposition under HBO.
So again, the actual studies aren't showing big changes.
For the drugs studied, yes. Now, results might differ for drugs metabolized by other enzyme systems, not just CYP450.
Okay, so summarizing the whole pharmacokinetic picture, absorption, distribution, metabolism, elimination, it sounds like while there are loads of ways high pressure and oxygen could theoretically mess with things, the actual evidence we have, which is admittedly limited, doesn't point to major clinically significant changes for most drugs during a typical short hyperbaric oxygen therapy session.
That's a pretty good summary, yeah. Clinicians should still be aware of the potential effects on blood flow, on enzymes. But widespread, significant kinetic effects haven't really jumped out in the literature yet.
And 5E remains the go-to for getting drugs in reliably.
For acute therapies in the chamber, absolutely. It bypasses any potential absorption variability.
Okay, great. Now for the final piece, and maybe the most fascinating, pharmacodynamic considerations. This is all about how drugs might directly interact with the effects of the increased oxygen itself, right? Changing how the drug works or how the oxygen affects the body.
Exactly. These are the interactions that modify the ultimate pharmacological outcome. And a key area here is looking at drugs that might make us less tolerant to oxygen toxicity.
Making oxygen potentially more dangerous.
Yes. And things that affect our metabolic rate are really central here. Generally, if your body temperature is higher or your metabolism is running faster, you're more susceptible to oxygen toxicity. Being cooler, hypothermia, is protective.
Okay, so things that rev up the body's engine can make us more sensitive to high oxygen. What are some examples of medications that might do this?
Thyroid replacement medication is one area to consider. In animals, having an overactive thyroid, hyperthyroidism, dramatically increases the risk of oxygen toxicity.
Makes sense. Higher metabolic rate.
Exactly. And the opposite, having an underactive thyroid, is protective. Now, for humans, someone just taking thyroid meds to stay euthyroid, normal function, not considered higher risk.
Yeah.
But active Graves' disease, which causes hyperthyroidism, that does increase seizure risk.
Okay. What else?
Glucocorticoids, think steroids, adrenaline. They also seem to sensitize the body to oxygen toxicity in animal models. Removing the adrenal glands in rats was protective.
So patients on high-dose steroids need extra caution.
Yes, careful monitoring is needed, and maybe even prophylactic preventative anti-seizure meds. There are anecdotal reports that the early warning signs of oxygen toxicity might appear faster in these patients.
But seizures haven't been a big issue with standard treatments.
Right. Steroid-mediated seizures haven't really been seen with the shorter HBO exposures, like the standard U.S. Navy treatment tables.
Good. Anything else boosting sensitivity?
Well, theoretically, anything stimulating the sympathetic nervous system could increase susceptibility by raising metabolic rate. But we lack much human evidence here. Animal research does show sympathetic activation during oxygen seizures. And drugs like caffeine and amphetamine, the animal data is actually conflicting. Some studies even suggest low doses might be protective somehow.
Weird. Okay, you also mentioned central vasodilators, mafenide acetate, and acetazolamide. How do they fit in?
Right, these drugs inhibit an enzyme called carbonic anhydrase. This leads to CO2 retention, a buildup of carbon dioxide in the body.
Okay.
Now, hyperbaric oxygen itself can make the brain's breathing centers less sensitive to CO2. So add these drugs, and you get even more CO2 retention.
And that's bad because
increased CO2 dilates blood vessels in the brain. More blood flow means more oxygen delivery to the brain tissue, which can actually speed up the onset of oxygen toxicity seizures.
Ah, okay. So practical advice.
Mafenide acetate cream, it's an antimicrobial sometimes used on burns. It has this effect. It should be completely removed before going in the chamber. The risk just outweighs the benefit there.
Got it. And acetazolamide.
Acetazolamide, used for things like altitude sickness or glaucoma, has shown in rats it can shorten the time to oxygen seizures, though some studies suggested protection at lower doses. It's complex.
Human data.
Lacking. But it's probably wise to consider preventative anti-seizure meds if acetazolamide has to be used at higher pressures, say above 2 ATA, and avoided above 2 ATA if you possibly can.
Okay, so those are things that can make us more sensitive to oxygen. What about the flip side? Are there drugs that might actually increase our tolerance, make us more resistant to oxygen toxicity?
There are a few that have shown some promise, mostly in animal studies. Vitamin E or alpha-tocopherol is a big one.
The antioxidant?
Exactly. It scavenges those harmful free radicals produced by high oxygen. Mice deficient in vitamin E die more easily in HBO. Giving them vitamin E protects against lung toxicity and even raises the seizure threshold.
Any clinical use?
Some clinicians do recommend patients take maybe 400 units orally before a standard 90-minute treatment based on this.
Interesting. What else?
Propranolol. It's a beta blocker that gets into the brain. It's been shown to delay oxygen seizures in mice and rats, possibly by helping maintain energy levels in the CNS.
So should people take it preventatively?
Probably not recommended just for that purpose.
Okay.
But people already taking it for other reasons might be slightly more resilient to oxygen toxicity.
Okay. Anything else?
Tromethamine, or THAM, it's a buffering agent, helps counteract the CO2 buildup that can happen with HBO. It showed protection against both lung and brain oxygen toxicity in rats.
Makes sense if CO2 worsens toxicity.
Right. And also chlorpromazine and promethazine, older drugs thought to have effects on the sympathetic system, they also reduced oxygen toxicity in rats.
It's fascinating that some drugs might offer a bit of protection. Okay, let's talk about some specific medications that are commonly used and any special considerations for the chamber. Anticonvulsants seem key.
They are. They can be used to prevent or treat seizures during HBO, obviously. But using them preventatively needs careful thought.
Why's that?
Because if you suppress the convulsions, the outward sign of toxicity, but you still exceed the safe limits for oxygen pressure and time, you can mask the warning signs and potentially allow permanent damage to the central nervous system to occur silently. Animal studies showed this.
Yikes. But it's okay within limits.
Yes. In human exposures kept within standard limits, typically up to 90 minutes at 3 ATA or less, permanent damage hasn't been reported with prophylactic use.
So when might preventative use be considered?
Maybe in specific high-risk situations. Patients with a fever, those with severe toxic infections like gas gangrene, patients on high-dose steroids, or individuals known to have a low seizure threshold already.
Okay. What about specific anticonvulsant drugs like barbiturates, phenytoin, benzodiazepines? Any quirks with them in HBO?
Barbiturates, like phenobarbital, work by slowing down the CNS via GABA receptors. A potential issue is they can also depress breathing, which could lead to CO2 retention similar to opioids.
Ah, that CO2 issue again.
Exactly. Animal studies suggest their potency or duration might be altered in hyperbaric environments. Phenobarbital has been used preventatively without reported problems, but you definitely need to monitor breathing and maybe even CO2 levels.
Okay, phenytoin.
Its effectiveness in preventing oxygen convulsions isn't really well established. Animal studies didn't show much effect in normal animals. There's one human case report suggesting it helps stop an ongoing oxygen seizure, but that's limited evidence.
And benzodiazepines, like diazepam, Valium.
They also work on GABA receptors, similar mechanism to barbiturates. Diazepam has been used preventatively against oxygen seizures without reported issues. Clonazepam worked in cats, but it's oral only, not for acute seizures.
What about treating a seizure if it happens?
Diazepam, midazolam, lorazepam are often recommended for stopping seizures in the chamber. There's a suggestion from animal studies that you might need larger doses than usual, possibly due to reduced receptor binding under pressure.
Higher doses. Any rebound sedation issues?
No evidence of that, but obviously close monitoring of breathing and mental status is crucial if you're giving higher doses.
Right. Okay, what about pain medications? Opioids first.
Opioid analgesics, yeah, they can increase the risk of oxygen toxicity, primarily through that CO2 retention again. They depress respiration by making the brain less sensitive to CO2 levels. Less breathing means higher arterial PCO2, which dilates brain blood vessels, delivers more oxygen to brain tissue, and can speed up the onset of oxygen convulsions.
So careful monitoring is key.
Absolutely. Close monitoring of respiratory rate. Patients should be instructed, even stimulated, to take deep breaths if their breathing slows down.
Interesting side note.
Hyperbaric oxygen itself has shown some pain-relieving effects at opioid receptors in rats. Less so in opioid-tolerant rats, though. But generally, the pharmacodynamics, how opioid drugs work, seem retained under HBO.
Okay. And non-opioid analgesics, aspirin, Tylenol, ibuprofen.
Usual doses, they're not known to potentiate or worsen oxygen toxicity. Their effectiveness seems unimpaired. There's really little clinical evidence to back up old theoretical concerns about aspirin, for example.
Good. Now, are there any drugs considered absolutely incompatible with hyperbaric oxygen, like definite don't mix situations because of enhanced drug toxicity?
Yes, there are a couple of important ones, particularly from the chemotherapy world. Cisplatin is one.
Okay. Why?
Cisplatin interferes with DNA synthesis and also impairs wound healing. In mice, combining HBO with cisplatin negatively affected the strength of surgical wounds. While effects on kidney and ear toxicity were mixed in rodents, the big concern is hindering wound healing. So it's generally considered contraindicated if the goal of HBO is to promote healing, like for radiation tissue damage.
But emergencies might be different.
Exactly. In life-threatening situations like carbon monoxide poisoning or gas gangrene, the need for HBO might override the wound healing concern.
Okay. What's the other big one?
Doxorubicin, another chemo drug. It works partly by generating free radicals and has known cardiac toxicity.
Free radicals plus high oxygen sounds like a bad mix.
That's the concern. It's generally considered contraindicated, based mainly on older studies in mice showing increased mortality when both were used together.
Is the evidence clear-cut?
Not entirely. There are conflicting rodent studies on mortality and wound healing, and one even suggested HBO might reduce the heart toxicity. Human follow-up data hasn't shown differences in cancer mortality with HBO pretreatment. But because of the potential for harm and lack of strong evidence for combining them, the standard advice is to avoid it. Some recommend waiting at least 3 days between the last doxorubicin dose and starting HBO. More research is definitely needed here.
Okay, those are really critical contraindications to be aware of. Let's move to drugs commonly used with HBO or ones needing special thought. Insulin and anti-hyperglycemic seems crucial given the potential effects on blood sugar.
Absolutely critical. Hyperbaric oxygen has a very clear effect. It potentiates insulin activity. It makes insulin work better.
Meaning blood sugar drops.
Consistently, yes.
Okay.
In diabetic patients, studies show average glucose drops anywhere from 31 to 51 milli-GDL during a single HBO session. Longer courses of therapy have even improved glucose tolerance and fasting glucose.
Does it affect non-diabetics too?
Yes, possibly a moderate effect even in non-diabetics. Increased insulin sensitivity has been seen across the board, obese, non-obese, with or without diabetes.
Do we know why?
The exact mechanism isn't fully nailed down. Potential factors include lower glucagon levels, higher interleukin-6, muscles getting better at using oxygen, maybe effects on carotid body chemoreceptors. Several possibilities.
So the bottom line for diabetics is a risk of
Hypoglycemia. Dangerously low blood sugar. It's a significant pharmacodynamic effect that absolutely has to be accounted for.
How common is it?
One large review found about a 1.5% incidence of glucose dropping below 70 milli-GDL. Risk factors were having a pretreatment glucose below 150 and having type 1 diabetes. Interestingly, insulin use itself wasn't identified as a risk factor in that study, but the underlying condition was.
So what's the practical management?
Close monitoring of glucose is essential. Check before every treatment. Empiric reductions in insulin doses might be necessary. Be aware that insulin sensitizers or oral hypoglycemics might also have a more pronounced effect.
And have treatment ready.
Definitely. Have orange juice, glucose tabs, or even injectable 50% glucose available in case of a hypoglycemic event. And document that pre-treatment glucose. Some places use a threshold, maybe around 110 milli-GDL, below which they might give a glucose supplement before starting.
Given that risk, careful monitoring sounds absolutely vital. Okay, what about sympathomimetics, vasoactive drugs, things affecting blood pressure and heart rate, and antihypertensives generally?
Right. The general trend seems to be that HBO potentiates or enhances the effects of drugs that constrict blood vessels and slow the heart rate.
Okay.
And conversely, it might reduce the effectiveness of drugs that dilate blood vessels or inhibit the sympathetic nervous system.
Any evidence for that?
Yeah, and in vitro studies on rat aortas show they constrict with HBO and become less responsive to vasodilators like nitric oxide or norepinephrine. Rat studies also showed blunted effects for various types of antihypertensives, while vasoconstrictive effects were potentiated.
Human data.
Limited. One human in vitro study showed a less pronounced response to phentolamine, an alpha blocker under hyperoxia. Data on many specific antihypertensives is scarce. Dihydropyridine calcium channel blockers, like amlodipine, seem relatively safe, though the reflex tachycardia they sometimes cause might be blunted by HBO.
Any practical advice based on this?
Because the negative chronotropic effects the heart rate slowing seem potentially enhanced, it might be prudent to give beta blockers or non-dihydropyridine calcium channel blockers after the HBO session, rather than right before.
And monitor closely.
Definitely. Monitor heart rate and blood pressure closely during the treatment, especially in patients on any cardiovascular meds.
Okay, makes sense. What about bleomycin, another chemo drug known for lung toxicity risk? How does that interact?
Yeah, there's a significant theoretical concern. Bleomycin's lung toxicity is thought to be worsened by free radicals, which HBO increases and lessened by antioxidants. Animal studies did show synergy a worse effect when combining 100% oxygen and bleomycin in rats.
So contraindicated.
Surprisingly, despite the theory, there haven't been documented human cases of bleomycin lung toxicity directly caused by HBO therapy.
Really?
Yeah. A case series looking at patients with a history of bleomycin use who later got HBO found it was safe, provided they had a proper lung evaluation beforehand and the frequency of HBO treatments was increased gradually.
So a history isn't an absolute no.
The general consensus now is that if the bleomycin exposure was more than, say, 3 months prior and the patient has no current signs of lung compromise, it shouldn't automatically rule out HBO therapy if it's needed.
That's good news for some patients. Okay, what about disulfiram, the medication used to deter alcohol consumption and abuse?
Disulfiram. The evidence on its interaction with oxygen toxicity is pretty conflicting, actually.
Oh, so?
Well, there's a theoretical risk it could enhance toxicity by blocking the production of superoxide dismutase, SOD, a key antioxidant enzyme. Some animal studies using very high doses did show increased lung toxicity and mortality in rats exposed to oxygen. But the doses in those animal studies were way higher than human therapeutic doses. And importantly, there are no human reports of increased oxygen toxicity linked to disulfiram use.
Huh. Anything else?
Yes. Counterintuitively, some research by Faman actually suggested that pre-treating animals with disulfiram protected them against oxygen toxicity, maybe by acting as a free radical scavenger itself.
So maybe protective.
Possibly. While its efficacy in blocking oxygen seizures in humans hasn't been proven in controlled trials, it's no longer considered a contraindication for HBO. Lack of clinical harm, plus that potential protective effect.
Another interesting twist. Okay, what about ethanol, alcohol itself? It's often a factor in situations leading to HBO, like CO poisoning or DCS.
Right. Alcohol intoxication is a common comorbidity. Animal studies in rats suggested that very high pressures, like over 12 ATA, might actually antagonize some of the motor impairment from alcohol, even if brain alcohol levels went up.
And does HBO sober people up?
No. In humans, HBO doesn't significantly lower blood alcohol levels or induce sobering. A key point, though, is that the post-alcoholic state, being dehydrated, might predispose someone to decompression sickness.
But does acute intoxication worsen oxygen toxicity risk?
It doesn't seem to seriously predispose patients to oxygen toxicity or seizures during a standard HBO treatment.
Okay, a few more categories. Anesthetics. If someone needs anesthesia in the chamber?
Big considerations there. For volatile or gaseous anesthetics, the concentration delivered has to be reduced proportionally to the pressure increase, because the partial pressure is what matters.
Right. Effective percentage goes up.
Exactly. And obviously, flammable anesthetics are an absolute no-no.
What about non-gaseous ones?
They have advantages because their effective concentration doesn't change with pressure. Ketamine can be used, but needs trained personnel. Local and regional blocks generally work fine without modification. General anesthesia in a hyperbaric chamber is complex, needs full OR safeguards, and is pretty rare these days.
Okay. Lidocaine. Used as a local anesthetic and sometimes for heart rhythms or neurological issues.
Yeah, lidocaine. There's conflicting experimental data on whether it helps protect the brain after an air embolism. Some cat studies showed benefit, others showed no difference from HBO alone.
What about in humans, like divers?
A retrospective look at divers with neurological DCS treated with lidocaine didn't find any difference in outcomes or side effects compared to those without, but it was likely an underpowered study. So whether there's a real benefit needs more investigation.
But is it safe to use with HBO?
It appears safe to administer, yes. And its kinetics, how the body handles it, seem unchanged by HBO based on that earlier study we mentioned.
Okay. Digitalis or digoxin? Heart medications.
Very limited evidence here. Some animal data suggest HBO, specifically the high oxygen, not just pressure, might increase the dose of digitalis needed to trigger ventricular fibrillation.
Does HBO help treat digitalis toxicity?
Not studied in humans for that, not a routine antidote. And the effects of normal therapeutic doses during HBO haven't really been studied either.
Any theoretical concerns?
Well, HBO tends to decrease cardiac output via reduced heart rate. Digitalis also affects heart rate, so potential for additive effects there. Close monitoring of heart rate and ECG is wise for patients on digitalis during HBO.
Got it. Heparin, the blood thinner.
Heparin. It's really unknown if HBO alters its anticoagulant effects directly. There's a theoretical concern it might predispose to bleeding, maybe from hyperoxic damage to tissues or vessels.
Like bleeding in the ear with DCS.
That's been suggested, discouraged by some in DCS, but data is sparse. One prospective study didn't find increased eardrum bleeding in anticoagulated patients during HBO, but did see more nosebleeds.
Animal data.
Mixed. Some dog studies showed intracranial bleeding with heparin after air embolism. Rat studies suggested increased bleeding from hyperoxic lung lesions with heparin. But heparin has also been used experimentally with HBO in treating things like DCS with mixed results.
What about human use in emergencies?
Some clinicians use it empirically in severe DCS. It's been considered for air embolism, maybe to help with the no reflow phenomenon. But there are no controlled human studies post-embolization. Hart reported using it in about 44 cases of air embolism or DCS without apparent harm, but again, not controlled data.
Okay, a lot of unknowns there too. Last category. Phenothiazines, antipsychotics, and antidepressants.
Right. Antipsychotics affect various brain receptors, serotonin, dopamine, acetylcholine. Some older ones, like chlorpromazine and prochlorperazine, actually reduced oxygen-induced lymphedema and seizures in mice.
So potentially protective.
Seems so. Chlorpromazine showed considerable CNS protection against oxygen seizures in Bean's research. Others, like lithium haloperidol, also showed some protection in mice.
Yeah.
The mechanism isn't totally clear, maybe sympathetic suppression, maybe effects on GABA levels.
So generally safe with HBO.
They appear to be safe, yes. But remember, just because a drug might prevent a seizure doesn't mean the underlying oxygen toxicity isn't happening if you exceed safe pressure time limits.
Good point. And antidepressants.
Very little data connecting antidepressants and HBO. One rat study on fluoxetine, Prozac, suggested a slight benefit in decompression sickness, possibly due to anti-inflammatory effects. But that's about it.
Okay, that covers a huge range of drug classes. Finally, let's just touch on antimicrobials, especially since HBO itself has some infection-fighting properties. Any key interactions there?
Yes, that's a really active area, and the interactions are complex. HBO is antimicrobial itself to some degree.
Right.
Sometimes it seems to work synergistically with antibiotics. For instance, HBO plus penicillin was better than either alone against strep myositis in mice. Same for HBO plus cefazolin against staph osteomyelitis.
So enhanced killing.
Sometimes. HBO enhanced ciprofloxacin penetration into Pseudomonas biofilms and boosted imitinum killing of Pseudomonas in vitro. It also seemed to enhance amphotericin B killing of Candida in vitro. And linezolid penetration into diabetic foot ulcer tissue was improved during HBO.
But not always helpful.
Not always. Penicillin resistance actually increased for Staph aureus under very high heliox pressure in one study. Vancomycin kidney toxicity was enhanced in rats with HBO, though they used high vanco doses. Aminoglycosides are mixed. HBO didn't help gentamasantobromycin cross the blood-brain barrier, didn't reduce amikacin ear toxicity, but did improve survival with amikacin against Pseudomonas infection compared to HBO alone. Yet resistance to gentamicin increased for E. coli and Salmonella with heliox in other studies.
Wow.
And for antifungals, while HBO enhanced ampho-B killing in vitro, it didn't improve cure rates in a live animal model of zeomycosis. It did seem to protect ketoconazol's effectiveness against Candida in vitro, though.
So it really depends on the specific bug, the specific drug, and the specific situation.
Absolutely. It's a very nuanced relationship. Synergy, antagonism, effects on toxicity, effects on penetration. It varies a lot.
Wow, okay, that is a lot to digest. It really underscores that we just can't assume drugs will work exactly the same way when you add high pressure and high oxygen into the mix.
Absolutely not. To kind of bring it all together, the big takeaway is that while many medications appear to maintain their general effectiveness under hyperbaric oxygen, there are numerous, really specific considerations. These span everything from how you store the drug in the chamber to how the body might handle it differently, the kinetics, and crucially, how the drug might interact with the physiological effects of the oxygen itself, the dynamics.
And it's clear, listening to all this, that there's still a lot of unknowns, a lot of we think or animal studies suggest, but not definitive human data.
Exactly. The scarcity of human data for many of these interactions, combined with the sheer impossibility of studying every single drug combination with HBO, means there are significant gaps in our knowledge.
So what's a key piece of advice for you, our listener, or maybe for healthcare providers who might be facing using a medication alongside hyperbaric oxygen therapy?
I think the most practical recommendation is this. Whenever a new drug, or even a familiar drug in a new context, is being considered for use with hyperbaric oxygen, it's absolutely essential to pause and carefully consider that drug's known pharmacology.
Thinking about.
Thinking about its mechanism of action, how it's normally handled by the body, and any potential ways, even theoretical ones, that the high pressure or high oxygen levels might alter its kinetics or dynamics. This kind of proactive thinking can help anticipate and hopefully avoid potential adverse effects.
So vigilance and informed decision-making are key.
Absolutely. It really underscores the need for ongoing vigilance in this very specialized area of medicine.
That's really valuable guidance, and it brings us to our final thought for you to ponder. Considering the expanding applications of hyperbaric oxygen therapy, how might future research best prioritize the systematic investigation of these complex drug interactions? How do we ensure we develop the safest, most effective treatment protocols going forward?
Yeah. That's the critical question for the field.
Definitely something to consider. Thanks for taking this deep dive with us today.